I've been asked to go right back to basics to what is mesothelioma. I know that some of you will, you'll have a very varied level of knowledge. Some of you will have done a lot of reading and others will be here for the first time. So I am actually going to strip it right back to basics. I apologise if it's too simple for some. Hopefully it's not too complex for anyone. So you might wonder why a Western Australian is talking to you about mesothelioma when you've got plenty of experts of your own here. Well, I come from a town, Perth, down here. And this is a map of the Australian mines and mineral deposits. And up here where the arrow is a mining town, Wittenoom. That's was one of the biggest crucidolite asbestos mines in the world. So we have lots of people who have been through Wittenoom many years ago, and they and their families are now affected by mesothelioma. So it's a real focus for us. And just some pictures of the natural beauty of the area. But unfortunately, the mines exposed children, their parents, the workers, and of course here shipbuilding, train yards, and electricians, carpenters, and those working in the insulation industry are people who are at risk that we share between our two countries. So again, right back to basics. What causes mesothelioma? As I'm sure most of you must know, crucidolite asbestos and other asbestos fibres are the dominant cause of mesothelioma. Almost everybody, if you look hard enough, will have a history of exposure somewhere, and those that we cannot find a history of exposure on the history almost certainly have been exposed, we just can't find it. But there are possibly some other fibres, including some natural fibres that are present in countries such as Turkey and also places in the United States that are geographically distributed that may give a higher risk of mesothelioma. And what's so special about these fibres is the size and shape. You can see that these are like little sharp needles. And what that means is that they can be inhaled as we breathe into the trachea, go into the lung and penetrate right through to the pleura. The pleura being the site of the pleural mesothelioma cancer, and normally it's like two little thin membranes of cling film or plastic food wrap. It's that thin, and there's a little bit of fluid in between. It enables the normal lung to slide up and down as we breathe inside the chest cavity. But that's where asbestos fibres lodge, and over many, many years cause the genetic changes that lead to cancer. And this is a slide of Australian data that shows the use of asbestos increasing, peaking in 1975 when asbestos was predominantly banned, and the incidence of mesothelioma peaking in 2015, 40 years later. And the same data is available in the United States. We see that 40 years between the inhalation of asbestos fibres and people developing the cancer. Now, it may be 20 and it may be 50 in some individuals, but that's the ballpark figure. So what diseases are caused by asbestos? Well, we're all here today to talk about malignant mesothelioma, which is a cancer of the mesothelium. But that is in the pleura, the lining of the lung, also the peritoneum, the lining of the abdomen, and more rarely in the pericardium, which lines the heart, and the tunica vaginalis, which lines the testes. However, what may be less known is that lung cancer can also be caused by asbestos. And then we have a number of other cancers that are probably higher in incidence with people who have had asbestos exposure, including larynx, esophagus and ovary. And of course, asbestosis and pleural plaques. Asbestosis is a devastating disease in itself, but it's not a cancer. So what is cancer in the very, very simplest of terms? Well, we have a normal cell, and then something causes DNA damage. And in this instance, it is the asbestos fibres, probably with inflammation as well as physical damage, and eventually a transformation of a cell. But in fact, it's not just one set of DNA damage. usually it's multiple stepwise DNA damage. And in families that may have some, for example, the BAP1 gene mutation that you may have heard of, that might be just the first step in what we call a multi-step set of mutations that can cause cancer. So once you have that critical mass of mutations, the normal controls over cell division and cell death are lost. Normally, our cells will replicate, grow and divide just enough to replace other dead cells within very, very strict controls, and cells will basically suicide. They'll kill themselves off once they have DNA damage, for example, that stops safe replication. But in cancer cells, that's no longer happening. And what we see then is a build-up of cells that form a tumour. So it grows in the pleura. When we're talking about pleural mesothelioma, we have two different parts of the pleura, the visceral pleura over the lung and the parietal pleura over the lining of the chest wall. And most commonly, both of these are involved. So what are the early symptoms? Well, it can start silently, and tragically that means that it's very, very difficult to detect early. And unlike breast cancer or prostate cancer, there is not really any early detection and no early detection program that can lead to cure. It then grows like a rind around the lung. If you think of a rind of an orange, if you think of an orange with segments leading up into it, the mesothelioma is like that, growing as a rind and forcing its way up through the segments as well. The first signs can often be breathlessness from fluid build-up around the lungs. Chest pain is also common, tiredness and fatigue, weight loss and poor appetite. Night sweats are quite common as well, and fevers. And sometimes it can be an incidental finding on a chest X-ray for some other reason, and a little bit of fluid is seen, and that is then pursued further. So on the left here is a normal chest X-ray. The black is the air in the lungs. Around the outside we see the ribs. There's your backbone there, and the heart is that blob in the middle. In somebody with mesothelioma, this is the left-hand side. We're still seeing the blob of the heart, but we're also seeing a lump on the side here on the pleura, and that's a tumour mass, and probably some fluid down the bottom. But that doesn't give us a very good picture. We can't see closely exactly what areas are involved, exactly how much tumour there is, whether it would be possible to have treatment or to measure chemotherapy, measure response to chemotherapy. And that's why we more commonly use CT scans. Now, if you think about this as crossways across a person, got the head out the back of the screen and tail leading in, legs leading into the auditorium. So this is the breastbone at the front, backbone at the back. The ribs are the little white bits coming around the outside, and in the middle is the heart and large blood vessels, and those black areas, that's air in the lungs. And this is a normal CT where you can see that there is nothing in between the white of the rib and the black of the lungs. This is a CT scan of someone with quite advanced mesothelioma. And what you see is that on the right side here, again thinking of your person with the head out the back and legs into the auditorium, this is actually the right-hand side and this is the left. So in between the white of the ribs and the black of the lungs, here we're seeing a thickness of tumour that's going all around, and that would go from the top to the bottom of the chest. And that's the sort of disease that we can see and measure when we're looking to see whether somebody is responding to chemotherapy treatment. So mesothelioma is diagnosed, we need a tissue biopsy. The chest X-ray or the CT scan, they're indicative of mesothelioma but not diagnostic. And then the next step may be to take fluid from around the lung. That can certainly give a very strong index of suspicion, and in some parts of the world can be diagnostic. And biopsy with CT scan or ultrasound localization or a pleuroscopy, so a mini telescope, or even an open surgical biopsy to take numerous samples and get the diagnosis confirmed. Now, I do want to note that the diagnosis can be quite technically challenging, and sometimes underneath the microscope it's just not clear that something is a mesothelioma, even though it's suspicious. So repeated attempts to confirm the diagnosis is not always a medical error. Now, let's hope this video works. This one does. The next one I think I have to get out of. This is a look down a telescope with thanks to my colleague Dr. Gary Lee. And this is the normal pleura. You can see the beating of the heart. These brown, purple lines are the ribs. It's smooth, it's shiny. This is pretty much a normal appearance. Now, once I move on the slide, this one doesn't work. Yeah. So, excuse me a moment. Oh, wrong one. We had this all sorted out. There we go. Okay. So this is mesothelioma. You can see it looks quite different in that you've got these little nodules, nodules of tumour over the ribs, and instead of being quite so shiny, it's rough and matte, and there's another area of tumour that would be suitable for biopsy, for example. Now, I'm going to get out of this. Okay. Just going to... Yeah. So the sort of exposure that people can have is very varied. And these are some of the examples of the exposure to asbestos that some of my patients have had. Someone who worked at Wittenoom, the asbestos mine, for 3 days and left because of the dust. He didn't even get paid. And last year he was diagnosed with mesothelioma. A young woman who helped her dad build an extension to their house to make a new bedroom when she was a teenager in the 1970s. An electrician, someone working for a print media company who used asbestos-cased crucibles for hot lead. And a gentleman who worked in a number of odd jobs, often in construction, but we could never actually identify his exposure to asbestos. So it can affect many people, often men more than women, and that's often due to occupational exposure. So when people talk about prognosis in mesothelioma, I don't want to go into any great detail here because I'm sure you've all been on the internet and seen all sorts of numbers. But what I do want to emphasise is that prognostic information absolutely needs to be individualised for each person. We have a world of difference between early disease that is found incidentally or due to a fluid collection, and that person may have minimal tumour, no symptoms, and treatment can be delayed or surgery offered. And then at the other opposite extreme, we've got somebody who presents with very late disease with a lot of pain, rapidly increasing breathlessness, a bulky tumour, and all of those symptoms of weight loss, night sweats, fatigue and poor appetite. People who may be too unwell or have too many additional medical problems for treatment. So I would urge anyone whose doctor has taken a textbook prognosis and given a certain number of months, for example, to ask somebody who really knows about and treats mesothelioma to move towards a more individualised prognosis, what may actually be appropriate for you as an individual. So in 2015, where are we up to? What can conventional medicine do to help? Well, I always like to start off by talking about controlling symptoms. That includes, importantly, draining fluid, which may be through indwelling pleural catheters or pleurodesis or surgical pleurodesis. Controlling pain is very important. If we don't control pain at the beginning, pain can become harder to control. So people who feel that they should grin and bear it, or that they like to they like to know that they have some pain or discomfort, because then they can monitor what's happening. These are stories that I hear from some of my patients. I like to encourage them to get good pain relief from the beginning. We can improve appetite and supplement diet to help weight loss, settle night sweats with corticosteroid medication or anti-inflammatory medication, and hopefully improve breathlessness. But what about anti-cancer treatments? So combination chemotherapy, and again, I haven't gone into a whole lot of detail here, but we're talking about drugs such as cisplatin and pemetrexed, or carboplatin and pemetrexed. We know from studies done in reported in 2003, that it can improve survival and quality of life and lung function. You may ask, how does chemotherapy improve quality of life? Well, if it is actually reducing tumour bulk and tumour symptoms, yes, it can improve quality of life. Clearly that's not in everybody, because it doesn't work in everybody. We need to do better, but we are still working with the same backbone of chemotherapy that we had in 2000 and 2004. Chemotherapy is not suitable for everybody, although the vast majority of people can have chemotherapy. It does have side effects. I don't need to tell anybody that. And it can be very effective for some people and completely ineffective for others. At the moment, there is no clear predictor of who it will work in and who it will not. And I guess the figures that I would normally use are that in 4 out of 10 people, there'll be a good shrinkage of tumour on the scan. In about 4 out of 10, it will stay much the same or shrink to a relatively small extent. And in about another 2 out of 10 people, it will keep marching on regardless. And that's not because chemotherapy has made the cancer worse, it's because chemotherapy just didn't work in that cancer. We also use radiotherapy to improve painful areas or tumour masses on the chest wall. And surgery is offered in some circumstances and in some locations. It is controversial, so I'm actually not going to get into that debate at all today. I've already covered this, haven't I? Okay, just the points that I didn't cover. Treatment with chemotherapy is given every 3 weeks, generally for up to 6 treatments, because if we keep on after 6 treatments with the cisplatin or the carboplatin drug, some side effects build up, for example, nerve damage or deafness, and we don't want people to develop overwhelming side effects from chemotherapy when we can stop it, when we don't know that carrying on after 6 cycles actually gives people any better benefit. In terms of side effects, we're looking at nausea, but we do use anti-nausea medication, and in most people manage to control nausea very well. Tiredness and loss of appetite can be more difficult. Low blood counts are often a problem for the doctor to worry about, but rarely will cause problems in the individuals themselves that people will notice. Numbness and tingling in fingers and toes, and rash. The goal of treatment is to shrink the tumour, so we can see that same CT scan with the rind of tumour around, and that has shrunk to some extent in the right-hand side after 3 cycles of chemotherapy. That's a moderate response. It's not the best response. It's not the worst response that I've seen, but it's not good enough. Surgical treatment. The role of radical surgery hasn't been clearly proven. Experts are divided. There are many people who strongly advocate for surgery, and I think more work remains to be done, so I'm going to sit on the fence there. But what I would say is absolutely critical is the surgical expertise and the volume of surgery that people do. Even radical surgery is not generally considered curative, but surgery is usually partnered with chemotherapy and or radiotherapy. We certainly hope that in some people that these sorts of aggressive treatments can leave them in a very good position for a very long time. What about clinical trials? So Mary's already spoken at quite some length about clinical trials. I'm going to give a little bit more general overview. Clinical trials are research studies in which people help doctors find ways to improve health and cancer care by answering a scientific question. And it's one of the final stages of a long cancer research program. We're looking at cancer prevention, diagnosis and treatment, and we're looking at safety as well or not it's effective. How many new drugs in clinical trials actually lead to new treatments? Well, there is a bit of a funnel here. So we've got discovery for agents that might look good in the laboratory and animal testing, then going through to phase 1, which is the first point at which human volunteers might be involved. Still, even those drugs that make it through to phase 1 and then phase 2, often testing in more specific tumour type, a smaller number will make it through to routine clinical care. So why don't you just give the new drug to everybody? Well, what we say is, well, that would be like comparing apples with oranges. Early testing of new drugs may give over-optimistic results because people in early clinical trials tend to be younger and fitter and often do well. When we compare that with historical data and how the general population with mesothelioma may do, it might look as though people on that clinical trial did particularly well, when in fact, perhaps because they were younger and fitter, they would have done well anyway. So the best test for a new treatment is to compare it with an existing standard treatment. And that's what randomisation is all about. In that way, you're able to compare apples with apples by taking a population and randomly deciding whether they go into the group control that have standard treatment and or the group that have the new investigational treatment. They may have one arm that contains a placebo drug, and that is something that looks like and is given in the same way as the drug that's being tested, usually with neither the doctor nor the person themselves knowing which they're on. And that's the best way to test results if they're really due to the drug rather than wishful thinking on the part of the doctor or the patient. In mesothelioma trials, usually placebo would only be used in a situation where people were having standard cisplatin and pemetrexed chemotherapy, for example, with or without a new drug in addition to that. But it's a long process. I'll run through that. Yeah. So just a little bit about evaluating the breakthroughs to finish up with. Every time something is reported in the media as a breakthrough, which is not clinically available, clearly it raises hopes for hundreds of patients and their families and raises many questions which they will bring back to their medical professionals. How can you understand what may be a real breakthrough? And what is credible information? Well, this is the medical research pyramid, a hierarchy of the quality and quantity of the studies that go on. Right down the bottom here, laboratory studies. Now, I'm not saying that the quality of these studies is not always high, but their applicability to the real-life situation is certainly lower. Laboratory studies in test tubes, for example, animal models in mice, single cases of people that were treated with a drug, case series, a group of people that were treated with a drug. The quality goes up as you get to the pinnacle of a randomised controlled trial in understanding just how well that information might apply to the larger group of people, for example, with mesothelioma. So a positive randomised controlled trial showing a benefit, showing that people live longer when they're on the new drug, may change what doctors recommend, may change what the FDA approves and what is generally reimbursed. Credible physicians will not recommend treatment on the basis of laboratory studies, animal models or single cases. But what they should be doing at that point is looking at ways to further study that information, particularly through phase 1 clinical trials. And then things that reach phase 2 clinical trials often are promising, extremely promising, but the real benefit remains unproven, and that's why they're often only available on the clinical trial, not as standard treatment, until they've been proven to work in a randomised controlled trial. So what about personal experience? Everybody hears anecdotes. An anecdote can be extremely powerful in giving people hope for the future when they hear how well somebody else has done. This sometimes applies to the use of unconventional treatments as well. And it's important to remember that people who've done well, or particularly badly, on a treatment, whether that's conventional or unconventional, may have a disease that's different to you as an individual. It might be slow-growing or fast-growing, early or late, completely removed, or that person may be too unfit for treatment. And they may be doing both conventional and unconventional treatments together. People who attract media attention are often people who are very, very well, and with a long-standing diagnosis will embrace lifestyle and mind-body techniques as well as alternative medicine. There may be other factors to consider. At the moment, in 2015, there is a lot of hope for the future. Targeted therapy does need a target, and those breakthroughs need to come from the laboratory. And as you heard last night at the dinner, breakthroughs need funding. Laboratory work is costly, but that's where we're going to get the next win for mesothelioma. Immunotherapies have had enormous promise in other cancers, and chemotherapy, new drugs, old drugs used in different ways, it's hopefully on the way out, but not that that's probably at least 10 years away before we do away completely with chemotherapy.